and contraction at the same time, and yeah! All right, are we ready now? Come on, Joey. Oh my God, it's only been a week, guys. We're back and we're talking knees. You got it. Okay, so first injury you'll see in the back and somewhere up there, Joey, you're gonna insert something. We're talking about Rashawn Slater and his horrible injury. This cut his season out, basically. Definitely a big injury. And you'll see it play out on the video. He blew out his patellar tendon. That's what we know. And that's a pretty significant injury when you actually consider it all. So when you look at the knee right here, okay, this is your patellar tendon. What he did was, wait, cut out that swear word. Okay, so what he did was he went he's running and then he gets somehow tackled and he kind of lands back and snaps his tendon. When you play it out, it's hard to see all the mechanisms of injury because you only have one two-dimensional perspective. And if you had all of that and you had live real-time kinematics inside the knee, you would see it all. We don't have that. We have an external displaced visualization of what's going on in the knee. The cameras are external. You have a dissociated, displaced visualization. However, somehow or the other, the contraction, typically it's eccentric. You guys should know this by heart. Come on. I know you guys know this. The eccentric loading through the patellar tendon, you're talking about, this is pretty stable. You've got collagen fibers, all of this patellar tendon, and of course there's retinaculum, there's fascia, there's all sorts of skin, tissues, muscles, nerves, vessels, and everything else, right? You know that. So what happens is that this is pulling, and then the hamstrings are also firing. So there's an imbalance in three-dimensional space about what's going on. And so what ends up happening is that you get this eccentric loading where you have firing, stretching, relaxation, and contraction at the same time, and yeah! Okay, so I'm not proud of this, I will say. Having an injury is never good. However, this is his tendon ripping off. Now, it didn't actually do that. For certain, I'm actually being overly dramatic. Can we make that more dramatic?
That's about as dramatic as it can get.
All right, okay. So that's dramatic. Now, typically patellar tendons, though, I was trying to snap it in the middle, they don't always rip off. Now, in kids, you could actually rip it off. I mean, there's a bone growth plate, you get incomplete ossification, and that ossification center rips off. That's a normal ossification center. It's cartilaginous, hasn't fully healed, so you take a piece of bone with you. Most of the times with patellar tendons, though, you get a rupture here, and then if you're old, everyone remembers the Clinton injury, it's a proximal quadriceps rupture. In younger athletes, you get it here. If you're not going to blow out your ACL, your meniscus, or your collaterals, at some point, someone's going to knock out their patellar tendon. And so in this particular case, he knocked out his patellar tendon, and I don't know where it is. We don't have the MRI. I'm not his surgeon. I'm not his physician. So basically, like I said, this is educational. It could have happened at the end, the insertion of the tendon. It could have happened anywhere along this midpoint or anywhere along the patellar tendon. Typically, that's what happens. You get a little bit of tendon flare here, and you get a little bit of the tendon here, and then you have to repair it. Or it just rips off completely. Bone heals better to bone than it does otherwise. And
You really broke
do you have glue? I think the pieces are, we have a piece. Okay, so, yeah, that ripped off. Okay, we'll have to repair that later. We'll have another knee. Do we have the budget for another knee?
You could just do surgery
I could do surgery. Hey, why don't we do that? I'll bring out my, tools from the garage, So in any case, the important thing is when you rupture your patellar tendon, you lose the kinematics that allow you to, what? Come on, people. If I'm doing this, if you don't have a patellar tendon, you can't do this, but it won't buckle like that. If I passively move it, it might, but this tendon is pulling this up. And if you don't have that ability, it's gonna rip off, okay? So That's a big problem. And what happens if you can't function with your patellar tendon because it's torn? You can't extend your knee. If you can't extend your knee, you can't walk, you can't put weight bearing on it. That's a big injury. He can't do what he was doing there anymore. And what about healing? What are we going to talk about? We're going to talk about what's the prognosis and outcome. This is not medical advice. In general, based on the biology, anatomy, biomechanics, and physiological characteristics of the knee, and in general, patellar tendon ruptures, assuming it's a certain type of mid-substance tear of the patellar tendon, and you use current, standard, state-of-the-art technology that may or may not include regenerative technology, depending on his treating surgeon, not me, you will have collagen healing to collagen, with some type of a reconstruction, which may or may not involve just suture. You may include a suture band, or you may include allograft if it's completely shredded, which can happen. Now, he's young, he's an athlete, he's gonna come back, I'm sure, hoping the best for you, Rashawn, but anything can happen. We don't know until you see the MRI and see him treated. Obviously, I'm not his treating surgeon. However, you're talking about 6 to 8 weeks for collagen to heal. However, the post-op rehab is the most important because, let's just say, for example, let's take this, sorry, Charlie, come on. I know, you had your moment last week. Let's just, give me a break, okay? So, oh, I think I tore something else as well. Well, okay, there we go. We'll just like tunnel that through there. We just kind of reconstructed his ACL. He's got a puny ACL, by the way. Anyway, we can talk about it later. So, you know, in this particular case, say you had a patellar tendon rupture that went off the insertion. And let's assume whether it has a flake of bone, a flake of tissue or not, but there's enough that you want to reconstruct it. Oftentimes, the standard procedure is that we either use bone tunnels or bone anchors. We pass it through the tendon, up and down, and then lock that into place. And essentially, we're cinching it down through special suture techniques. And you can read about that elsewhere. There's lots of websites about various ways to treat patellar tendons. The one thing about surgery is if there's 100 ways to treat something, that means no single treatment is ideal, okay? And that's another thing we learn. As we learn about the knee, sometimes we may learn that the surgery we're doing could be better, could be different. Or maybe we're doing surgery that needs to be improved in some manner or shifted just a little bit. So in any case, those are later conversations I'm gonna have with you as this season continues. Season, ooh, did you like that?
That was great.
Yeah, it was very media-esque, right? We're professionals here. Yeah, trust me, I'm a doctor. Actually, literally. Although, yeah, so here's a funny little snippet. I was actually at the doctor's office for my daughter who hurt her elbow, and she was, they were asking me questions, and I was sharing with them, and they said, "Oh, you're a doctor," and then my daughter goes, "No, he's not a doctor. He's a surgeon." My daughter said that. I was like, "Oh, that's awesome. That was really cool." So anyway, back to the patellar tendon. Come on, hey, we're on the operating table. Like, did I just take his whole? I took his whole quadriceps off. Okay, we don't do that in surgery. This is, as you can tell, this is not an operating room theater. Please do not assume that this is an OR. I am not sterile, people. Okay, you never know. Someone's gonna put a comment down below. I know. There's always someone, right? I know who you are. Anyway. So we basically cinch this down. Like, has anyone done, I'm sure some of you have done carpentry or any kind of construction work, or you're cinching down a tarp or something on your roof or anything like that. You have special anchors and then rope that you cinch down. Well, we basically have small, tiny ropes, levers, and anchors and bolts. Sometimes screws. We've sort of moved away from the concept of screws. They're mostly absorbable or partially absorbable, sometimes non-absorbable implants, depending on the location technique that we need, depending on it's a revision or primary surgery, all of that. And allograft. Allograft is tissue from the tissue bank. That's donated tissue from people that donated their tissue for science and for commercial purposes that can then be used, and it's cleaned and sterilized and then utilized. And the variability on allograft is for a whole other session we'll get into later in the season or in the year. The year's almost up, so maybe in 2026. Depending on how much you guys want to know, we can certainly talk about it. However, more than likely, it's good tissue that ripped apart, that is still intact enough to do traditional techniques without allograft and using sutures and anchors and bolts if needed, and you repair it down. Now, if it's mid-substance, you may or may not still use the anchors. You may or may not use anchors within the patellar, within the tibia, or in the patella itself, and then you basically use special suturing techniques up and down. Sometimes Krakow is sort of the gold standard that was often described, but there's so many different tissue variations and suture variations, and that's another topic. Hey, we just created a whole season right here on the fly. So there's different ways to repair it. Once it's repaired, then we're talking about healing. The biology of healing. We've talked about it in the last string of episodes. I know it was 3 years ago, but come on, stop bringing it up that it was 3 years ago. We're here now, in this moment. Isn't that what mindfulness is about?
There you go.
You be here now, in the moment. Yes. So, in this moment, and what happens is that the collagen, through biomechanical stimulation, they arrange their fibrils so that they actually heal in the right pattern. Now, again, we can't be linear in our thinking. This is not a hinge joint. It moves in 3 dimensions, right? Even with the patellar tendon, it moves in 3 dimensions. So even the rehabilitation has to occur based on natural, physiological, biomechanical, anatomical considerations, depending on the individual and their health and their activity and their nutrition. And there's so many facets of that go into play. And we're just starting to understand all of that through decades and decades of research, but there's still holes and gaps in what we know. And actually, that's part of kinesi as well. I keep bringing it up, but those gaps of knowledge and the mountain of data about what we don't know is what we're filling in. And there's hundreds of millions of data points per hour that we're filling in. And so it's going to be wonderful to see all that play out. However, right now, 6 to 8 weeks, you gradually increase your mobility. Again, in general, please do not quote me on this like medical advice specific to this patient or any specific injury. I know there's a lot of you out there that like to bet and gamble based on the return of athlete or an injury. This is not for you, okay? I don't gamble on people's health. We're not talking about betting whether or not someone is going to return in a certain time frame. You do what you do, that's great. But we're not playing any odds here, okay? We're just talking about in general. So did I just discount gambling? I'm sorry. I didn't.
It will not be a sponsor.
I don't think gambling will be a sponsor. Well, maybe they will. Maybe they'll find it entertaining. No, you don't get a gambling tattoo. God, Charlie. Anyway, so 6 to 8 weeks, and then you get into the 3 to 6 months. And again, rehabilitation is about phases of rehabilitation. You have to be patient specific. Now, sometimes in various formats, people talk about standard rehabilitation based on time. Everyone's timeline is different. An athlete's timeline may be more accelerated. An individual who's a recreational athlete with the same injury who sits at a desk is going to have a completely different timeline. They may be back to work within a couple of weeks, whereas the athlete clearly is not going to be back to playing until maybe sometime between 6 and 12 months. Now that's a broad area. Now, could he come back in 3 months? Personally, unlikely, I think, just based on my overall understanding of biomechanics and healing. Because what else is important? I know you know this. I want to hear the words. We're going to spell it out down below. How many words? How many letters? Proprioception. Did I do that right? Do you see the letters? You will, right? Okay. Proprioception. So proprioception is the most important. And then what else after that? Mental health, the sports health, the engagement of the athlete to trust and be confident in his knee. Because right now we may think we have objective parameters for returning to sport, but the amount of data required to actually truly be objective in return to sport in athletics is not there yet. Remember those big gaps, the mountains of data. We're filling all that in with understanding injuries, injury prevention, rehabilitation, and athletic performance. And when that is done, we truly understand. Now, there's lots of ways to do that. I'm not saying that I know the right way. Please understand. All I'm saying is that we have gaps of knowledge that need to be filled in, and that's why we don't always know when an athlete returns. There are some athletes that may return from an ACL within 6 months. There are some that wait 9 to 12 months or 2 years. Everyone's different. We already know about how Klay Thompson, Achilles, ACL, multiple injuries, rehabilitation, overlapping injuries. There are a lot of things, nutrition, physiological, mental health. Can you trust your knee? And if you had, say, high quality precision kinematic data on your knee, and you were saying, hey, that graph and data and that number of performance helps me define what it feels like when I'm back on the field, back on the court, back in the pool, back in the gym. You gain confidence. And so that confidence is what the athlete needs. So I almost may shuffle that again. It's like, is proprioception and rehabilitation as important as sports psychology and mental health for the athlete? It's hard to say. In one respect, it's as important for an elderly patient with a hip fracture to have the confidence in their leg again as it is for the ACL injury or even the baseball player, tennis player, soccer player, and basketball player. So there's a lot of facets in it. The patellar tendon will heal, and I know, Rashawn Slater, you're going to go through rehabilitation and recovery, and here's hoping you do the best recovery you can.